Okay.
All right, excellent. Um, do we have any good, let's say, good boys amongst us to lead?
I think we should recite it.
All right, then. So let's recite then. All right, after three, two, one. O God of all
The Lord
creation,
creation. Grant this one
grant this
request.
one request. Help us to
Help
build
us to
a
build
nation
a nation
When
where no one is
man is
oppressed.
oppressed, and so
So
peace
peace
and
and
plenty.
plenty, Nigeria may be
Yeah,
blessed.
in Amen. All right. On that note, I once again would like to welcome us all to this very, very important conversation. To kick us open, like I said, this webinar was convened or is convened by the National Task Force on the Decriminalization of Suicide in Nigeria. I would like to invite the chair, the chairperson of the task force, to open us up with a remark. Prof, please.
Greetings, everyone. It's a pleasure to be here this afternoon and to have you all with us. We're excited that you're able to make out time from what I know must be very busy schedules to join us this afternoon. But I imagine that many of us in the room recognize how important the topic is. Today, we're talking about suicide prevention, and we are centering the voices of people who have had experience of suicidal ideation or attempts today. And I just want to thank you for joining us for this very important, very sensitive topic. The National Task Force on Decriminalization of Attempted Suicide was inaugurated by the Honorable Minister in 2024 to help move the needle forward on decriminalizing attempted suicide in Nigeria. Our terms of reference include advocacy and stakeholder engagement, as well as development of a bill that will be passed by the National Assembly. One of the reasons for this task force is to ensure that different people, different stakeholders are aware of what we're doing and that this is not a policy that is made unilaterally, but a policy that draws from the experiences of people on the ground and in particular the lived experiences of people. If you attended the last one, you know that we had a very interactive session. You know that it was very engaging and not just engaging from the point of view of entertainment, but engaging from the point of view of hearing different viewpoints. And so today we have people with lived experience sharing their experiences and helping us to begin to think very broadly, but also deeply about how we can proceed with suicide prevention. We thank you for joining the members of the task force on this journey. We work very much in collaboration with the National Mental Health Program at the Federal Ministry of Health. And I invite you again to participate meaningfully. And I thank you very much for joining us this afternoon. Abdul?
Thank you very much, Prof, for that very warm remark. Um, so yes, like she said, today's conversation is very, very important because it's a conversation about lives, it's a conversation about dignity and the power of listening. So I hope today we'll be able to listen, truly listen, and not just listen to respond. So just for context setting, the theme for today's webinar is Lived Experience at the Center of Suicide Prevention, Why Voices Matter. Of course, we know in Nigeria and globally, conversations around suicide are often shaped by stigma, silence, And to make things worse, even in our own context here in Nigeria, additional layer of legal frameworks that even discourages help seeking because it's decriminalized. So increasingly, we've also learned that we need to do something critical. Um, and of course, also even something more important, that those who have lived through suicidal distress are not just part of the story, but they are central to the solutions. So hence why today's webinar is really, really important. And I'm really excited to hear from our three big speakers today. So today we'll be hearing from those individuals. And we have somebody, please, we can mute your mic. Try to mute your mic, please. Or maybe if we can do that centrally, and then we can open the mics when it's time for Q&As. So today, like I was saying, we'll be hearing from individuals and advocates who bring both personal insights and professional experience to this conversation. So before we proceed, I would like to really acknowledge that this topic can be deeply personal and emotional. So it's important that we intentionally create a safe and respectful space for everyone, please. And as such, I would just like to, read out a few guidelines that would help us to be, to create that safe space. Of course, we should engage with empathy and, and be non-judgmental. This is a non-judgmental space. It's a safe space, like I said. As much as possible, also let's try to avoid graphic descriptions or use of harmful languages. Let's also try, and everyone is free to share, everyone, but only to the level that you're comfortable. Yeah. So please, if you're not comfortable to share any story, or you feel a question is intrusive or it's too personal, you are at liberty not to respond, please. And of course, we should also be very sensitive to respect that decision. And if at any point any of us feels overwhelmed, please feel free to step away briefly, and then when you're more relaxed, you can then come back. And of course, we should also understand that there's no right way to have lived experience. What counts is every voice. On that note, I would like to kick us off with a short video just to set the mood, so that like we said, the topic can be quite sensitive. So to get us going, IT, if we're ready, we can play a short video. Well, maybe before then, let me just try to also read out the structure for the day. We've had our national anthem, we've had the opening remarks. I am going through some opening statements now. In a short while, we'll be having a video. It's less than a minute. After the video, we'll be gauging our mood using Mentimeter. And then after that, we'll be going to our panelists. We'll be introducing who our panelists are. We'll be having 2 rounds of introductions, each followed by a Q&A to make it interactive. We'll be having both the Mentimeter and the chat function on the Zoom for people to interact. So at any point, use whichever one that is convenient for you. And of course, we'd also love to hear from people during the Q&As. And then just before we end, we'll be having some remarks by the coordinator of the National Mental Health Program, and then have a closing remarks and close out. So that's how the day will be structured today. So able to go to the Mentimeter. Can we paste the link for the Mentimeter in the chat box, please? So we have a question for you. We have a poll. We just want to gauge how we all feel about the subject matter today. So can we please share the link for the Mentimeter and the poll? And the question we're asking you is essentially, hello? We want to understand how comfortable you are discussing suicidal thoughts openly. within your family or community? Fortunately, we've not had okay, so we have okay. So I think all right, that's fine. So I guess the question is, what obstacles do survivors of suicide attempts face in seeking help? We have judgment, stigma, shame, ridicule, ostracization. Shame seems to be stigma, stigma and shame, lack of actual help. So even if you speak out, there is no help. That's interesting. Stigma, shame, and fear. Wow, that's quite strong. That's interesting. Lack of empathy, judging, depression, lack of actual help. Wow, that's quite interesting. All right, thank you very much for your responses. So some of the key themes that came out are stigma, judgment, and lack of actual help. And then, of course, fear, stigmatization, no therapy, lack of empathy, demon possessed. That's something that we hear commonly in this part of our world. Um, Unfortunately. All right. Um, on that note, I would like us to make some progress. So thank you very much for sharing those your thoughts. So maybe before we proceed, I would like to remind us that at the beginning we did ask us how we're doing. Most times when we say how are you feeling, you say yeah, okay, even though you're not okay. So let's remember it's okay to say you are not okay. And if anyone you know or you yourself is experiencing any distress, we encourage you to seek support from any available mental health service or trusted individuals. You are not alone. So just to put us as just to remind us that. So today we are privileged to have three incredible speakers who will be guiding us through this discussion from different but complementary perspectives. Uh, uh, one is um, one is a person with lived experience, an advocate, sharing personal insights on stigma and barriers. Um, we have another person who is a civil society representative, highlighting community realities and responses. And our last speaker, but not the least, is an experienced advocate connecting lived experience to policy and practice. So, as you can see, Ms. Olayinka Omowumi Aturu currently serves as the principal medical laboratory scientist in the Department of Hematology and Blood Bank at the University College Hospital, Ibadan. She's an individual with lived experience of bipolar disorder, diagnosed at the age of 13. She has dedicated over 2 decades to raising awareness, reducing stigma, and amplifying the voices of persons with psychosocial disabilities. Mrs. Aturu is widely recognized for her resilience, storytelling, and committed to advancing um, public health and mental health outcomes across Nigeria and beyond. Thank you very much, Mr. Lainka, for agreeing to share your stories with us. And the young man, the smiling face you see on your screen is Mr. Yinka Shito. He's a development professional and a programs manager at the African Philanthropy Forum, where he leads efforts to build strong peer networks among funders and philanthropists, amongst philanthropists to strengthen strategic philanthropy in Africa. Um, Thank you, Yinka. And lastly is Adiola Agumbiade. I hope I pronounced that very well, as it's proper Nigerian. She's a Nigerian lawyer and a mental health policy advocate. She currently serves as the legal and policy associate at She Rights Women Mental Health Initiative, where she contributes to the organization's legal infrastructure and policy development across its programs and partnerships. In addition to her legal practice, Adiola has extensive experience in mental health lived experience as a mental health lived experience advisor and public health patient patient health involvement contributor at leading research institutions. So these are our three speakers today. I would like us to, yes, we can't clap, we can't hear you, but I saw somebody clapping. So if we can all put our hands together for them, please, for agreeing to share their personal stories with us today. So we would have, like I said earlier, we'll be having 2 rounds of engagements. We'll try and make it as interactive as possible. So the first round will be followed by a Q&A. And well, please encourage to share our reflections in the chats, ask questions respectfully. Once again, I would like to remind us that this is a safe space, and also engage actively throughout the session. So as we begin, I'd like us to, listen, truly listen, not for the sake of responding, for the sake of listening. So to begin, we'll start with, I'll start with Adiola. Adiola, can you hear me? Just so that we can test our mic.
Oh, yes, I can. Hello.
Excellent, lovely. Thank you again. It would be nice maybe if you can start with a 1 minute introduction of yourself and and your story. But the question I would like you to answer for us is, from your lived experience, what forms of stigma or misunderstanding had the greatest impact on your journey, and how did they affect your willingness to seek support?
Okay. Thank you very much for that question. So I'll first start with a little bit of an introduction. And the thing is, when I received the invitation to be a speaker in this webinar, I spent a lot of time thinking about what exactly would be the key message that I would like to share. So I'll do a little story before I start with the answering of the question. So yes, I was in my third year of university when I learned about criminalization of attempted suicide in Nigeria. Before then, I knew about it in the way that most Nigerians did. You know that there's a punishment, and of course, I found it really strange. But for the first time in that criminal law class, I read exactly what the words of the law said. And also around the same time, I'd been diagnosed with depression, a condition that had suicidal ideation as one of the symptoms. And I see that over time, I realized that the primary justification that most people have for criminalization of suicide in Nigeria is that it can prevent suicide attempts. But in my experience, that is not true. I remember thinking to myself that I must succeed, that because of this law, I must make sure I succeed. And for me, it created a situation where success meant dying and failure meant living. And I had my therapy sessions during COVID, and it was close to my university back then. I had to travel 1 hour for it. And I was so terrified every time I had to travel for it because I thought that, some of my classmates who were in the criminal law class that day would see me and they would know the reason I was there and they would remember the things that were taught that day. And that kept me from speaking about my mental health for a really, really, really long time. And oftentimes I would think about that day in class if I learned something different, Or even years ago, when I knew about the law, if I learned something different, instead of punishment, the law spoke about care, community-based care. And early in my advocacy journey, when I finally had the courage to speak up, I used to use this analogy a lot. I would tell my friends, my sisters, my family that if someone that has malaria is vomiting, would you punish the person? Of course not. So why do we do the same for suicide? Why do we not recognize that as a symptom of a mental health condition? And the truth is that care helps, care does improve. At Right Woman, we have a support team that provides free teletherapy and also toll-free helpline counseling. And in the past 10 years, we've realized that we've been able to prevent over 200 suicide attempts. That is a big, significant number because of care. And it's because of the care and support I received years ago. That's the reason I'm able to speak today. Of course, not criminalization of suicide. So to the question, what sort of stigma has had the greatest impact on my journey? I would say public stigma. I knew there were negative stereotypes that had become normalized to the point where it was accepted, and I internalized those stereotypes. So when I realized I needed support, in my head, I'd become one of those people that needed help, one of those people that I talked about, and it made me hesitate to seek support, and it really caused me to live in denial for many years. So yes, that's the answer to that first question. Thank you.
Thank you very much, Adiola, for sharing that powerful and honest reflection. And I think it does remind us of how, just real and complex these challenges are. Many of us we read it and we just hear it, but hearing you speak now, just makes it real because it's human beings. It's about real lives. Thank you very much once again. So like I said, we'll be having two rounds, but if you have any, please feel free to use the chat function, to drop your thoughts as we go along. We'll come back to that after this first round. So now we're going to broaden our lens to the community level, and I would like to invite Yinka to share some insights. So Yinka, based on your work in communities. Yinka, can you hear me? First of all, mic
Yes,
check.
I can hear you. Good afternoon.
Excellent, excellent. So based on your work in communities, what would you say are the most common gaps or barriers people face in accessing support for suicidal distress?
Okay, thank you very much for that question. And I will change the question because, well, the microphone is with me and I can do whatever I like, I think. So rather than speak about my work in communities, I want to first draw from my personal experience and then we can make extrapolations about that to the community that I come from. And to everyone who is listening, well, I mean, I like to say that forget about my bio, any of you may have seen earlier. I am your regular guy, your neighbor. Some of you we probably even went to school together. Some of us are probably, from the same village or city or what have you. And so I will answer that question, but of course, like I've warned you, trigger warning, attempted suicide coming at some point. I think one of the most important barriers that I have faced, that the people that I work with continue to face, is the fact that the support systems or care systems, and this is not just from a healthcare vantage point, in this context are very often inaccessible. And not just that they are inaccessible, even when they are accessible, they are unprepared. Please stay with me. One of the issues that I had, I will remember, so I feel like until very recently, I feel like I'm the kind of person who all my life I have just wanted to die. I don't know if there's more of me, like more people like me in the world, but there's just something uncomfortable about existing in this world and in the ways that I grew up that made me just not want to be here. And I remember that one of the first times that I ever was vocal about my feelings to any human being was in secondary school. At the back, I actually remember very clearly at the back of my English language notebook. You know how you're supposed to do your classwork in the regular front page. At the back, while the teacher is talking, sometimes I'll be in my head and I'll be doodling. And this one time, I actually wrote what I what essentially was my suicide note. I remember the English teacher taking our notes for marking, and at the back of the notebook was my suicide note. And he read it. His reaction, so he was actually very impressed by it. From an English language teacher standpoint, he considered it to be a very, very well written piece of work. And he was, boasting about it to the teachers and staff room and saying, look, this is such an excellent piece of writing. And then the guidance counselor of the school happened to walk by and he read the same poem and was like, no, that's not a poem, that's a cry for help. I say that to say that I was in a system that was supposed to support my education or my growing into flourishing as a wholesome individual. But the first person who would actually recognize that I needed help was not the person who I was in closest proximity all the time, which is my teacher, which is to say that very often we do not have the skills required to recognize what is needed to support people who are in distress, would not have the kind of professionals required, would not have the right language about these things in order to be helpful. There's also the fact that, anyway, so that's on one end. Sort of related to this unpreparedness of of support systems is also the language about it. I remember much. I see there's a hand for a question, but I imagine we'll take that later. And so, very often when people say, "Oh, why did this person attempt to take their own life?" or "Why did they take their own life?" it's often not a question of people not wanting to seek help or people not expressing their distress. Is that our eyes trained to recognize what these issues are in the first place? And so, the fact that these systems continue to fail us or be absent in the ways that they are is very important. Another one that I would like to also point out is the language about suicide. And I don't. I promised myself I wasn't going to say this, but I just have to. I think one of the first places where I found the right language and words for the things that I was feeling was when I began to work with an organization called CHILD. Interestingly, Professor Chelucci, chairs CHILD also, and for the first time, I began to experience attempted suicide from more than just, oh my God, I have a personal issue that I have to talk to my therapists about. I began to see within the framework of this is something that other people experience, which is to say that we often don't have the language or the visibility, healthy visibility of certain kinds that allow people consider ways out. So that's a moment. I'll come back to that much later, but I don't want to belabor the point. Another thing I'm recognizing more and more, especially with communities, is that we tend to over medicalize this issue and ignore structural realities. And I say this because after my issue in secondary school, and I don't want to tell you how that ends because it could potentially put my parents in bad light. I would then go on to get into university and essentially struggle through all my 4 years of school. I was struggling to stay in school. I was struggling. There were days that I would just blank out. I would have no memory of what the days were, of what I was doing with my life. Along the line, someone whom I was living with, decided, look, this was an issue. We had to go to the hospital. I did go to the teaching hospital in the school that I was in, and I got treatment. But when I say I got treatment, what I mean is I got a ton of antidepressants. And so, yes, I was medicated, but I was still not functioning. I did not have support. I did not have anyone checking to see how I was doing or how I was. I didn't even know that it was required. I just thought if I take my medication, then I'll be fine. Which is to say that this issue, and allow me name it because I think words are powerful, when it comes to people attempting suicide or considering suicide or suicide ideation, it is not just a mental health issue. Very often, this sits at the intersection of all kinds of things. Poverty for so many people, the reason many people want to honor life themselves is because they don't feel that they have the resources required to live healthy lives. Sometimes it's grief, sometimes it's trauma, sometimes it's social exclusion, sometimes it is displacement, as we're seeing more and more as a result of things like floodings, internal displacements, and what have you. So very often when you see a person who ideates suicide or attempts to take their own life, the question we should be asking from a community standpoint isn't, what is wrong with this person? The question should actually be, what happened to this person that makes them think it's an issue? In what issues the systems fail them such that they fail to consider this? And I'd like to use the example of malaria. When you ask someone what is the cause of malaria, they could tell you it's a plasmodium parasite. I like to think differently. I like to think that it is the absence of mosquito-treated nets, presence of stagnant water within vicinities that create the groundwork for what we then experience as malaria. So when we are going to talk about what it means to stop people from not just attempting suicide, but essentially creating a condition where it's not an option, it means that we have to be conscious of of basic structural realities. And so people don't experience suicidal distress in a vacuum, right? Another thing I also say, and please stop me, Abdulaziz, if I'm going on for too long, is
You
that
can round up in the next few minutes.
I can round up. Okay, I will give you the time on that, but excuse me. I'll just leave it there for now. Thank you very much.
No. Finish this thought. Finish this thought, please.
Okay. I think another thing we don't recognize within communities is that suicide ideation or suicide attempts often exist within clusters. And I say it this way. I remember very strongly when I was a teenager with the rise of certain films like, I shouldn't say the film, so some of you don't guess my age. is there more and more, it seemed like in mainstream media and in books, there were more references to suicide as things that were sometimes glorified. I will never forget a body of work that I read in university. It is titled 16 Notes on How to Take a Life by Akachi, a brilliant young Nigerian writer who ended up taking his own life. I remember reading it and feeling so seen by this body of work that began to dream of how I would do mine. His experience influenced me. There's other media like 13 Reasons Why, which has been evidentially documented to increase, I mean, it contributed to an astronomic rise in attempted suicide by American teenagers. There's also the fact that in certain countries, so it means when you see something happen, you know that it's possible. And so with more of those reference points comes the tendency that it's more likely to happen. We're not taking stock of this data. A lot of us, either as public health professionals or as people who work within communities, these things are not isolated incidents. I actually remember the last time that I attempted to take my own life. One of the things that pushed me was because someone I did know was, I don't want to go into personal stories too much as I would love to, which is to say that we need to be careful of how mental health conditions, how suicide ideation is represented within mainstream media, because communities consume them and they determine what is healthy, what is acceptable, what becomes normal for certain groups. So I will leave it there for now. Thank you very much.
Thank you very much, Inka. That was quite powerful. As you can tell from the reactions, and thank you for grounding us in the realities within communities as well. Yeah, some few things you mentioned there. Language, use of language, indeed, and even in terms of knowledge and skills to identify these things. Yeah, unfortunately, that's the reality that we live in. But yes, if we must succeed, those are some of the things that we have to address or confront. All right, we'll be going to our last but not the least, obviously, speaker, Olainka. Mic check, Olainka, are you there?
Yes, I am.
Excellent.
I am.
All right. Okay, so we'll be moving away from community practice to systems and policy now. So, Olainka, I'll be inviting you to help us understand how lived experience can shape meaningful change at that level, at policy level. So, of course, you will start by, giving us a brief, bio about yourself, and then if you can help us respond to this question, which is how can lived experiences like yours be meaningfully integrated into policies and programs rather than being tokenistic?
All right. Thank you very much. Thank you for having me here. My name is Olainka Omomiaturu. I'm a person with lived experience, having been diagnosed of a mental health condition for over 25 years now. I was diagnosed at 13, my teenage years. Now I'm in my early 40s. So looking back at my journey now, I see it as a mixture of several challenges, periods of difficulty, recovery, and resilience and hope. So I will start by this. When I was growing up, I used to be an outlier, meaning that I was very, very accurate in my academics. That I was having high grades, to the extent that in my common entrance days, I was told to come and write my common entrance in theory. We have what is called MCQ, that's multiple choice questions. So I passed excellently to the extent that I was supposed to come and rewrite it in theory. That was at Bola Comparative High School. But I was diagnosed age 13, so everything just, declined for me. It crashed my academics. I almost did not graduate from secondary school. To the extent that my first episode was in my senior secondary school, class 1. That was in University College in Lekuro. I broke down. I was brought to UCH, University College Hospital Ibadan, where I was admitted into the psychiatric ward. And, I kept on having repeated episodes. I could just concentrate. My mom took it upon herself to take extracurricular classes for me. She made it upon herself to write out my lesson note, having teacher for each subject. Luckily for me, I passed my senior secondary school exams. Then moving on to higher education, I didn't know what to, my tertiary education, I didn't know what to do next. I sought advice from my psychiatrist. So I was told to do medical lab science, that medical laboratory science. It was still then in school of, University College Hospital Ibadan. So on getting to admission, I kept on having repeated episodes to the extent that I won't be able to assimilate. So that was where my journey of suicide started. I was in my 200 levels a year, after which I stepped down. I was in my final year, let me put it like this. I was in my final year of my immediate set, of my actual set. So I was told to step down to 200 level, of which I was now battling with accumulated carryovers. Having to, maybe you couldn't pass your exam, what I mean by carryovers. So I don't know if my classmates are listening right now, that's an evidence. So I was down, I was hopeless, full of shame, rejection, nowhere to go to. So I attempted suicide. I survived. Not that I wanted to end my life, but it was an urgent, silent cry for help. Not that I was not reaching out for help, but I was overwhelmed with my conditions that I couldn't just, I was like, oh, this is the end of it. I couldn't move on. But I got support system from my mom, my psychiatrist, family, friends. They encouraged me. And luckily I graduated. I graduated in medical laboratory science. Now I'm a principal medical laboratory science in the same hospital where I was admitted as a psychiatric patient. I'm still working there. So it shows that when you have support system, working for you, appropriate support system working for you, it goes a long way. And even in yourself, you have to have this boldness, this resilient spirit. I call it fighting spirit. It's survive, a warrior spirit that come to race, come sunshine, you're going to make it. So speaking of that, I also happen to be an alumnus of CCAM. That is, I completed my postgraduate studies in Center for Child Adolescent and Mental Health. And not only that, I also a peer researcher with Support Succeed Africa. That is supports comprehensive care and empowerment for persons with disabilities. All these areas I have passed through, they have kind of shaped me and kind of broadened my horizon to a extent that it has improved my self-esteem. I'm now talking to people with other mental health conditions, encouraging them that they should not give up. And having you to have suicide attempts is not that you are low, you have low self-esteem, or maybe you are weak. It's normal for you not to be okay. That is what people don't understand. It is actually normal for you. So far, you have your life going on with you. The moments of downward moment for everyone, but it's just normal for you to cry out for help. But what most people don't realize that they feel maybe those people attempting suicide, they are demonic, or maybe they are passing downcast, they are caused, or maybe they are not visible. But so far you have your brain in your head, you can have mental breakdown at any time. So back to the question now. For you also be inculcated into the policy and the practice, we need to have adequate support system. I will tell you this, before this webinar, that was on Thursday, I was down, I was totally down. And why was I down? I just had should I say, flashbacks. So some things that happened at that same Thursday to me, and I was just extremely down. Where did I go to? I went to my psychiatrist. She was able to calm me down in person of Dr. Belawuza. Dr. Tolulope Teresa Belawuza, she was able to calm me down, of which I was still speaking with other psychiatrists, that is Professor Migbodun, talking to, they all form like I would say like a force, to push me up that, you can do this, you can be been through a loss. This is just a phase, I want to say that for everyone passing through maybe any suicidal thoughts or suicidal attempts, it is a phase. You will always go through that phase. So for us to be incorporated into the process of reforms, we have to have adequate support system, not only medication, but there is what we call CBT, that is cognitive behavioral therapy. Some persons don't even need medication. They just need someone to talk to them, to encourage them, to give them words of affirmation. What do I mean by words of affirmation? Some people, when you are passing through some things, the way they talk that out to you, they shout you down. But whereas some will lift you up with that such word, there's saying that sweet words brings, how do I put it now? Sweet words brings money from the pocket. There's a way you talk to a person, when somebody is over the blues, there's a way you talk to some persons. We need to have adequate support system and treatment that restores life. What I mean by treatment that restores life, when you are treating someone with person with lived experience, it has to be able to put them back into the society. And again, too, I want us to also have it, in case of policy, to also have what is called now, full implementation of the mental health law in Nigeria. Not just passing bills, it has to be implemented into the mental health law of Nigeria. Then also, we should also have person with lived experience being given opportunity for self-employment into the system. They should have a person with lived experience incorporated into the mental health sector. For instance, now in the education sector, we have persons, we have people that in the education sector and also the agricultural sector. They should also include person with lived experience into the employment sector in the health sector. And also they should also encourage peer support workers too. What I mean by peer support, can you hear me, please?
Very well.
Yes, we should also have peer support. Yes, we should also have peer support workers incorporated into the health system. What do I mean by peer support workers? Peer support workers are persons with lived experience that also aid other persons with mental health condition in hospital accompaniment. They encourage them with their life stories, with their recovery stories, so that they will also form like a force for those persons with lived experience to be able to achieve more. So they should also be incorporated into the employment system in the health sector. Then also, apart from that, we should also have persons with lived experience given allowances. Monthly allowances. This may be difficult, but we can together we can do it. Give them allowances so that they will have financial support. Maybe when they want to get their medications and have a livelihood, good livelihood. Then also we should also have mental health awareness in education system. What do I mean by this? They should have mental health studies incorporated into the curriculum of the education sector, so that in the primary, in the tertiary, and also at the kindergarten level. So they're not only having just counselors, we should have standard professional psychiatrists into training teachers. When you train teachers, when you train lecturers, when you train secondary school personnel, they will be able to identify if any student or any pupil that is going through such condition, so that they will be able to give them adequate support system. For instance, now when I was in school, you know, at that time, I don't think there was nothing like mental health, whatever. So it was just left to my mom, who happens to be a widow at the very time that she was just left alone with my psychiatrist. So they were able to form a force together to help me, because I was just imagining now that what if at that time I was arrested? You know, I won't be here today. I won't be a mother to my son. I won't be a principal medical laboratory scientist, no, attending to patients that need care in the hospital. And I'll also be an advocate, you know, for other persons with lived experience. So, and I said that we should also have what is called expanded community-based activities. You know, speaking with those with the we call them ballets in the Yoruba land, that they are the king makers in such communities, because they were able to identify those persons with lived experience. Because most people see them as an outcast, so they don't want to have anything to do with them. And also, we should also try and decriminalize attempted suicide. It is not a crime. It is just a silent cry for help. You know, some people, they are passing through situations that they're even ashamed to talk about it. So when I say I mean ashamed, that means they don't want anyone to hear. But at the same time, they need help. It's a silent cry. So I will want the government of Federal Republic of Nigeria to please attend to us, you know, and help we person with lived experience to live a better life. Yeah, thank you very much.
Thank you very, very much, Adeyinka, for sharing that very powerful story. Yeah, it's indeed, yours is quite a story of struggle, and but it's also a story of success, of what can happen if the system truly works. That's an example. I think some of the few things you said, you know, that's also aligned with what Adiola said, you know, in terms of understanding, you know, or the issues of creating the awareness, and also making implementation of the Mental Health Act. You know, they say the budget is a reflection of your values. And unfortunately, due to some of the issues that has been raised, you know, when we talked about, when we did that Mentimeter, you know, stigma came out very, very strongly. So, which is also a reflection of our awareness level in the country. So, as long as that awareness level or that stigma exists, it will also have a way of reflecting in all the things that, you know, we do, including our policies. So, hence why it's not surprising that even though the Mental Health Act has been passed, we still do not have any monetary or budgetary back into it, which is why the implementation is where it is. So thank you very much once again to all our speakers for sharing their very rich perspectives. And once again, I would like to, so before, just a few reminders. So please, we have the chat, the translation function. If you click on the, where is it now? On the, you can turn on the transcriptions if you want, if you need it. It's available. I'm just trying to look at where exactly that would be so that I can guide you. If you click on that more, you see captions. So just if you click on it, it will come up for you in case if you need that. So I would like to, you know, once again remind us, please, this is a safe space because you can see the trigger warning there. So please, as we are going to open the floor now for reactions and comments, I would like to remind us once again that this is a safe space. Please, let's be very intentional about that. Let's, you know, let's respond with empathy, engage with empathy. and respect, please. So on this note, please feel free to use the chat function if you want to. I can see we already have some questions there. But also if you want to, ask any questions, you can also raise your hands. We can use the next 10 to 15 minutes for that. But maybe to start with, I see that Al Hassan Abdullahi, you have a question on how do you handle the case of maybe seeing someone with mental health disorder who is trying to commit suicide, who is going through suicidal distress. Which support and assistance can I give him as a community health scientist? So any of our panelists, you can respond to that, please. Let me also go through. Olainka, can I give you that? All right, response. All right, Shitu, please go ahead to respond. I see you have your hands up. And then after that, I'll
Thank you very much. And yes, please, I'd be happy to take that. If I hear the question correctly, is what's the next step to support someone in your community who is experiencing signs of distress? First,
Yes.
you're a good person for even noticing. That's more than many people do. I think the natural next thing that you want to do is, first of all, provide a first line sort of assessment. How much of a risk are they to themselves, their immediate community? Provide as much support and succor as you can. Express sympathy. Now, beyond that, what is now important that you do is that you identify the host of this webinar have been very kind as to share some supportive resources that you can engage with. So what you want to do is find a close by, preferably a close by support system or a healthcare center, a primary healthcare center that you can refer them to. And beyond just active referral, please provide compassionate referral, where if possible, you can accompany them to access care in that regard to ensure that there's follow through, because one of the issues we have in healthcare settings is failure of referral. So if you can support them to seek care, and your job does not stop at referring them, you also want to ensure that you follow up as much as you can regularly, ensure that they are surrounded by community that is supportive, or place them in one if that is possible for you. I think that's some of the things you can do immediately. Thank you.
Excellent. Thank you, Inka. So I'll go to Ayanfe Initiative and then Ndeyo. Pardon my pronunciation, please, if I don't get it right. So over to you, Ayanfe Initiative.
Thank you very much. Good afternoon, everyone. I'm Dr. Olubukola Mobowale from Ayanfe Initiative. Ayanfe stands for Advocacy for Youth and Neglected Futures Empowerment. It's a non-profit organization located in Ibadan, Nigeria. And in the course of our work, we work with survivors of harmful traditional practices, some of them with suicidal ideations, and I think a couple have actually attempted. So my question would be to ask about, this is directed to the National Task Force. Is there any plan to maybe put something in place that would, right from the onset, assess the risk of suicide, because I've been looking at how we can, right from maybe as you are assessing someone right from the beginning, you already put like a risk assessment, maybe template or matrix. I will let you know that, oh, this person is has a high risk of suicide or, things like that. Is there any plan to put something like that in place? That's my question. Or is it even possible to do something like that? Thank you.
Thank you. Maybe we'll take 3 questions and then we'll then respond to them. All right. Thank
you so much. It's Ndayo, or you can say sunshine. Yeah, it means sunshine. That's sunshine. Yeah, that's my particular name. Thank you so much. I'm Dr. Iwat Ndayo. I'm the General Secretary of Health Sector Reform Coalition. Thank you so much for this opportunity and yielding the floor for me. I want to appreciate Ika too for his contribution. Mine is largely input about private healthcare and community practice role, in this, not just in suicidal tendencies, but brain health as a whole. And I want to draw attention to, I think around 1988, during the time of Dr. Kuti as the Minister for Health and Dr. Zoring Bay as the Director of Primary Health Care, and when we adopted primary health care central to our national health policy. And we added two components, community mental health and community oral health. Since then, the APSCDR is yet to, develop the protocols, and we have had the national policies on mental health. I'm sorry to use that because it should be brain health. They have developed that, but they are yet to, step it down to the subnational. Let us have, this thing incorporated into the mainstream of community practice, so that the preventive care and the supportive care, because we have the promotion, the prevention, and management, and probably rehabilitation and restoration, in the chain of continuum of care. So if we should look at the primary care, the community care, you're taking care of that, as they have done for ophthalmology. I think the eye care, community eye care is now fully incorporated. So we require that, this brain health, including suicidal tendencies, should also, the advocacy should be stepped up now. The incidence is high, because if you look at our country, people that have done even small research have confirmed that among the children, particularly in schools, universities, young kids, they are coming in with this. So we have to please press for this policy. We are open in the HRC to support this. The Health Sector Reform Coalition, as you are aware, 2011 pushing for the National Health Act, 2014 sent by the President. So we are open, and we want to suggest that we can move it forward from here. APSCDH could have been here. We should see the Minister for Health. We should make a memo and make sure that that component, 1988, is realized now, and probably care for the older persons, the dementia and related activity, brain situation, and then care, the oral care. So thank you so much. That is my own input, and thank you so much for the opportunity.
No, thank you very much. One of the essence of this webinar also is to really, build the necessary traction, have the necessary support that will allow us to achieve this. I'm happy that the national coordinator of the National Mental Health Program is here himself. So part of these things, they are very appropriate. I know there are quite a few efforts, here and there of organizations doing some of the things that you're mentioning now, but it's important that we all come together to do this. All right, I'll give Tabitha for this last round, and then I'll come to you after we responded to this question. So please, if you can keep it under 1 minute, that will be great, so that we can have maximum participation, please. Go ahead, Tabitha.
Thank you very much. Thank you for this program. What I wanted to ask is, for we that want to learn more about this, we want to be part of the solution in terms of providing assistance and help to people, whether on a personal or a bigger stage. How do we educate ourselves better so that we're not ignorant, so that we are aware, and so that we can actually be of more help to people around us from an educational standpoint? Thank you.
I love it. Short and sweet. So additional resources to be able to, equip yourself to support, right? All right. So the first question, I guess, I will allow the national chair, the chairperson, to respond to that. In terms of, and then I'll come back to the panelists to respond to the last question. The second question was a contribution.
Okay, sorry, I probably have, I don't know what the first question was now. If you can remind me. My recollection is that, somebody asked a question about the national policy. Is that what that question was about?
No, I think the question was around if there are some measures that could be put in place. Unfortunately, I didn't write it myself. Please, if the person that asked the first question, can you please repeat that question again?
Sorry, I'm not sure whether you're referring to this is an unfair initiative. Is this
Yes,
my
unfair initiative. Your
yes?
question.
Thank you very
Yes, your
much.
question, please.
Yes, I was asking about a risk assessment template. I work with
Okay. Yeah.
survivors of harmful traditional practices. Sometimes survivors of maybe victims of rape, and some of them have suicidal ideations, and even some have attempted. So I'm wondering whether we can do like something that can predict, like a predictive template to assess the risk of someone who might eventually become suicidal, or I don't know. I don't know if it's possible. Yeah, that's the question. Thank you.
Okay, thank you. I think that's above my pay grade. But thank you very much for asking that question. I think it's extremely important, even when we think about some of the things that have been shared earlier. For example, when Yinka shared what he shared about schools and teachers being able to identify what's going on. So I think, Abdul, that we might want to bring Dr. Ojo to answer that. I'm sure there are certain tools he can talk to us about. Some of the tools have been developed both by the program and those have been adapted from the WHO, etc. So, Dr. Joe, if you're in the room, can you please help us?
And I will also ask Dr. Ojo to add to the last question, which is around additional resources for, self-development around being able to be able to provide support on this.
Okay. Thank you so much for the question. Sorry, my background is not too great. So, yes, what can be done and risk assessment, what can be embedded. So, I think I would just say purely, sorry that I'm making this reference that I will refer you back to, but I think we should make it more publicly available. The National Suicide Prevention Strategic Framework speaks to all of this. And if we are talking about interventions for suicide prevention, they are at different levels. There are universal interventions, there are targeted interventions, there are community-based interventions. So, like you said, people that are at risk group, then there is targeted intervention that will have to be done for them. And part of that will be inculcating screening into the regular intervention that you have in that setting. There are things that are done at community level. Of course, if you are talking about healthcare setting, screening is part of the usual routine that should be put there. So at that level, at different level, there are different interventions. And for request for help for additional for capacity building, again, that's the National Suicide Prevention Strategic Framework is a fantastic document which speaks to what can anybody do about suicide prevention. What can we do at educational level? What can we do at a community level, Ministry of Women Affairs, workplace? So all these interventions are there. For people, they're placed for at community level, even training people for psychological first aid, befriending. There are quite a lot of interventions at different level. And as we have heard from people that have shared their experience today, even leveraging on existing infrastructures, teachers, school-based counselors, and there are evidence-based results. Evidence that have shown that leveraging on this existing infrastructure, building capacity to be able to act as frontliners are very, 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 very important. I don't know if that answers the questions for now. Thank you. Over.
Thank you, Doc. All right, I would now, so please, just being aware of time. So Al Hassan and Dr. Joshua, I will give you a minute each, please. And then we'll now go to our second round of questions to our panelists. Al Hassan, over to you, please. Al Hassan, your hand has been up for a while. You must be tired. Okay, if Al Hassan is not there, maybe we'll go to Dr. Joshua then. Dr. Joshua, I can see you're there. Go ahead.
Yes, Mr. Musa, you're very, very interesting as a moderator. I kind of like your joke about Al Hassan. That's why I was smiling. But thank you so much. I am very, very grateful for the opportunity to really share. I think I'd like to first acknowledge everyone who's taking an opportunity to really share their lived experience. It helps us and gives us perspectives and insight, and we're really grateful for this. Just for context, I co-host a mental health conference here in South Africa. It's actually co-located with the Africa Healthcare Endeavor. And we're grateful to some of our partners and stakeholders that makes it possible. And I said that to say this, that over the last 3 years, one of the things we've realized is that the healthcare system is stretched. And because of that, it becomes very important to start looking at training, capacitating, empowering community healthcare leaders and people who also want to be healthcare champions. So as African Institute of the Mind, which is the organization I started almost a decade ago, one of the things we have tried to do is to look at our global network and try and see how we can get various stakeholders to support us in creating something for Africa. And I said that to say this, that we are delighted that we now have an assessment tool that helps us to, in 60 seconds, get about 7 to 12 biomarkers after scanning a face. And I share that because of one of the questions that one of the ladies from, if I'm correct, I think is Ibadan, that asked a question, and Dr. Ojo kindly tried to respond. I think sometimes, time is also of essence while we are doing this. It will be nice to know if, the task force is really open to seeing how we can hold hands together to bring some of these solutions that have already been created. And I might I add that this solution is actually cleared by the FDA in America. And we have done, a POC of it with the healthcare department in Rwanda, and we're currently doing that in South Africa right now. I'm a Nigerian by birth, and our country really is very dear to me. Dr. Ojo knows what I'm talking about. He hosted me in Abuja, I think last year, and I enjoyed the Amala. Might I add that to conclude? Thank you so much.
Thank you very much, Doctor. I think it was very important that you mentioned you're Nigerian, because when you said you were from South Africa at the beginning, I'm sure many of us were like, huh? Okay. That was on the lighter note. Yes, so thank you very much for sharing. Okay, so we'll be moving to our second round. Maybe let me just read a couple of comments on the chat. Sima, he made a very long contribution. I won't be able to read all, but I think the summary of what you're saying is the role of the media plays and institutions, sometimes towards normalizing stigma, ridicule, and silence around suicide. So I think that was what you were trying to highlight. So it's important that we also look at that, and I think it's important also as a task force to also engage with the media, which is what is being done. Another contribution is okay. Somebody asked if all cases of suicide is connected to mental health. I don't know, maybe somebody can help respond to that. Any of your speakers or any of our professionals in the house can help respond to that. And it goes further to say, can the scope of suicide be expanded to mean the process of immolation rather than an eventual death, e.g., in the cases of bandits, drug addicts, etc. Who can respond to that for us?
Let me, is Dr. Gunwale in the house? Let me call on a member of the National Task Force.
Is there?
Dr. Gunwale, Dr. Gunwale, can you take that question around, is it always a question of mental health conditions? Is suicide always a result of mental health conditions, or are there other contributory factors, at least from an expert standpoint? I have to mention that Yinka spoke about it when he did speak, that there are various contributory factors, but I wanted Dr. Gunwale to speak to us from an expert perspective. Thank you.
Madam Chair, I'm really sorry. I'm on a public transport. I'm in transit. I'm able to speak loudly. Can you hear me?
Okay, you're excused. You're excused. Okay, Dr. Ojo, I don't know if I've seen anybody. Is Professor Bindo in the house? If Professor Bindo is in the house, please, I don't think I've seen him anyway, but okay. Otherwise, I'll go back to you, Dr. Ojo. If Professor Bindo is not around, can Dr. Joe respond to that? I think it's already been sort of, Yinka mentioned that we know that there are all kinds of contributory factors. There can be impulsive reactions, even from, immediately stressful situations. So somebody who hasn't really been in that frame of mind or had mental health conditions on an ongoing basis. That said, I mean, I've heard Dr. Gunwale talk about it, and I can just talk about it from what he has said, but I don't want to do that. I want to rely on an expert opinion. So Dr. Ojo, the ball is in your court. Please help us with that.
I wish I could just pass the ball around, but it has been kept in my court perpetually. Well, I think not just re-echoing what has been said, the thing is, what the evidence have shown is that people that attempted suicide are about 90% have underlying mental health condition. But even for mental health conditions, the truth is that we can't talk about one single cause. You talk about the biopsychosocial approach. And so attempted suicide is a big nexus that interwoven everything about society and our health. Social determinant of health, socioeconomic issues, quite a lot of things. And Yinka Balogun mentioned things, other people mentioned something, and he gave some quite very great illustration, and someone will say that there is no sick mind, there are only sick society. And so the issue of course, and there are impulsive suicidal attempts that people just at this, but the thing is, we have to look beyond mental health. And so that's why, again, it's also using that prism lens that you also have to, when we are trying to address suicide prevention, we look at it from a whole society, a government-wide, multi-sectoral approach. And so I don't know if what I've said answer that question to an extent. Thank you. Over.
Thank you, Doctor. And I'll also perhaps add from my very layman understanding. So I also just realized I didn't introduce myself properly. I did my name.
I'm gonna say that.
I'm Abdulaziz. Yeah, well, I've introduced my name, but not my other responsibilities. So I'm also a member of the National Task Force. I lead the Resource Mobilization Subcommittee. I'm also the country director for CBM Global in Nigeria. So we've recently implemented a research project to be precise, and what we saw clearly was how improvement in livelihoods also helps in addressing stigma and improving mental health conditions. So I will leave it there, so that I don't say things that are not appropriate. I wish Professor Obindo was here. Ngozi, I have seen you, but I'm really tempted to pretend I have not seen you just because of the time. Only if you promise you're gonna just use 30 seconds to say what you want to say.
Yeah.
All right.
Just give me a few seconds.
Okay,
in
please.
all these discussions, I've not seen survivors, to be part of the discourse. Myself, going personally, I'm a survivor. I've written suicide letter twice because I was supposed to be deported from Germany. That's about 2-3 decades ago, but it did not happen. You see, so I think bringing survivors into this discourse will also help to improve the quality of policies that are being made. About the stigmatization of people who are attempting suicide. Thank you.
Thank you very much, Ngozi. I guess you joined a little bit late, so you exposed yourself with your comment. So
yeah.
But which is okay. Your point is absolutely very noted, and hence why today's webinar is actually focused on survivors, lived experiences, and the theme specifically for this webinar is lived experience at the center of suicide preventions, why voices matter. And all our 3 speakers today are persons with lived experience, and you're going to hear them just now, because they are going into they'll be responding to the second round of questions. So on that note, Diola, mic check once again.
Hi.
Excellent. There you are. You've been quiet for a while, so time for you to speak. Because I'm aware of time, we have less than, we have about 23 minutes or 33 minutes to round up. So if you could be brief, please. So now we're looking at, we're moving forward since we're wrapping up. So we need to start looking at some solutions and recommendations. So what could have made a difference in your earlier in your life journey, from family, community, or institutions? And what message would you want decision makers to hear?
Okay, thank you for that question. I think it's a really important one. I think what would have made a primary difference would be having the right sort of information. Everything that delayed me seeking support, seeking help, and being able to speak about what I was going through was because I did not have the right sort of information. So if I had, for example, this sort of webinar early on when I knew about my mental health condition, that would have made a difference in my formative years. So what I do think is having that right sort of information and having that information come from a reliable source like this. So having persons with mental health conditions and lived experience being at the forefront of conversations like this, because our experiences do really matter. And sometimes I take part in a lot of research, and sometimes when I look at this research that don't have persons with lived experience involved, there are a lot of things that simply do not tally with our lived experience. So having this sort of information from persons with lived experience and also reliable bodies like the National Task Force on the Criminalisation of Suicide, attempted suicide, really does help in having the right information out there. So I think what would be my primary message is make the right information available from the right people.
Thank you very much, Adila. That was very short and sweet. Sometimes I wonder, because there are lots of, sayings. For example, there's a saying, for those of us that understand Hausa, that the dangari ake chengari, or meaning you conquer a city with an insider, or you that lives in the room, you're the one that knows where it leaks, or we even have another one that says you cannot shave somebody's head in his absence, or nothing for us without us. So then I wonder, why is it not even just common sense to center lived experience in these discussions, But what do I know? Thank you very much once again, Adiola, for that. Okay. Mr. Yinka, you there?
Yes, I am.
Excellent. So, what would you say are the community-based approaches that have shown promise, and how can they be strengthened or scaled up across the country and perhaps even regionally?
I would say an approach that can be strengthened, and it's one that we've known for years because of what our wisdom, our local wisdom teaches us. And it's a statement we all say that it takes a village to raise a child. I make the argument that if it takes a village to raise a child, then it takes a village to keep that child alive. And so essentially what that involves is creating healthy villages, creating communities that are safe, that people can exist in. And again, what that means is that people within communities have duty of care to one another. And so that means that one of the things that we can begin to do is ensure that people at whatever level, whether they be care professionals, whether they be leaders, are trained to identify suicide risk, beg pardon, can practice active listening, recognize warning signs, and like we shared in that example earlier, know how to utilize referral pathways. Because the thing is that when it comes to preventing people from attempting suicide, the success or failure does not happen in the office of the therapist, because that's not where people present. People present their warning signs in everyday conversations. And so we must create healthy villages where in those conversations we can begin to change the narrative. Related to that also is the fact that we recognize that some people more than others in villages have power. And what that means is that very often and actually, now I think about it, I was going to share a personal story, but again, in the interest of time, I would leave that out. I remember that there was one time, or I would argue, I would say one of the last times that I attempted suicide was on my birthday, which is coming up soon. Don't worry, guys, I'm safe. I had attempted to jump over a bridge in Benue, Makadi, and I would never forget it. And while I was just there, saying my last words, as it were, and deciding to jump, a truck driver stopped by the bridge and asked, "Young man, what are you doing here at this time? Why are you here?" And he asked me questions I couldn't exactly answer because I didn't have words. I just had a desire to exit this planet. And he, without me answering honestly what I was up to there, he convinced me to go back home, convinced me to call my parents, and I'm a much better person because of that. And so what that means is that every person in the village has power, some more than others, such as community leaders, faith leaders. Very often our pastors, our imams, for those who are religious, are the first places that we go to when we have issues. So it's important that we begin to engage these people more strategically in the quest to provide better mental health care and to prevent people from attempting suicide in the long run. And there was a question in the chat that I really liked that says, what role can employers play in providing occupational therapy as a result of an experience that he had with a friend? And I want to tell the story of, I know, well, I have already said it first, I've already referred to it earlier, so I'm free to do it now. Oops, I live in Nigeria. This is evidence because power just went out. When you look at the workplace, I think the workplace is a strategic opportunity for us to advance, to provide good mental health care. And if you look at it, adults spend a large part of our lives, about 2,000 hours per year working. Practically, what that means is that we spend more time at work than we actually do with family. I remember one of the times that I was, struggling with depression and what have you. It was at work that I found support. And so what that means is that workplaces are not neutral. Work can either become a protective factor where it provides you with community, with a sense of purpose, with stability, or it can be a risk factor because sometimes there's harassment, stress, burnout that aggravates these things. In my case, what I had was an employer who is actually Professor Cheluchi. I'm sorry, Prof, you can't hide, who was willing to not just provide health insurance as is expected of most employers, but to go the distance by ensuring that that insurance covered therapy in my case, which was beneficial for me. So what that means is that we need to encourage workplaces to inculcate wellness programs or provide support on the levels that they can. I think that is a very powerful entry point. Another way to do this, sort of this approach that I think are workable and scalable is something Dr. On here referenced earlier, is that it's important that we integrate mental health care as a whole into primary health care. Of course, Professor Ojo has mentioned the plans that we have to do that, what the policy provisions are. But, that looks like different things, and not just from a care standpoint. We referenced youth-based interventions. I mentioned how suicide can exist in clusters, and that one of the most critical phases of people's lives are within the ages of 18 to 25, where most mental illnesses, start to occur, people begin to experience these stresses. So it's important that we begin to pay more attention as society, as villages, like I said earlier, as healthcare professionals to provide support through these things. And I also want to say, because of the work that I do, and my little experience sort of informed my career choice, to say that the bulk does not stop with all these beautiful things that communities can do. Communities can do all these things, but honestly, resources are at the bedrock of all these things. It's important that, and like you said, Abdulaziz, earlier, it's important that we put our money where our mouth is. It's important that our budgets, priorities reflect that our budgets reflect what our true priorities are. And so with some of these, if we begin to employ these entry points, I believe that the future is bright for all of us in Nigeria. Thank you.
The future is bright indeed. But I'm not sure how we agree to that statement now in our country, but it is indeed bright. And I think one thing I really liked about what you said is the local wisdom. Most times we tend to neglect that. We're becoming very urbanized. Is that the word? Or where you don't even tend to know, you see your neighbor. I remember a couple of, sometimes in the office, we have our usual Monday morning meetings, and the staff, shared that, they were really happy that a colleague noticed that she wasn't feeling looking normal or looking okay, and just that simple act of asking, are you okay? Not just once, but are you truly okay? And then that person felt okay and comfortable to now, speak up. So I truly agree with you. We should really take genuine interest, in ourselves as a people. And unfortunately, I know we do have lots of issues, as a country now, but there are things that we need to, put first. All right. Thank you very much once again, Nika. Solayinka, so you'll have given us the last response. Are you there, Solayinka?
Yes, I am. Thank you. I am here.
Excellent. So just checking that your mic is still on. So in the context of suicide decriminalization, what practical steps? I know you've mentioned a couple earlier, but just wondering if you have additional suggestions. What practical steps should policymakers take to ensure supportive, not punitive responses?
Yes, thank you very much. One of the practical steps policymakers can inculcate is training. When you train personnel, especially in the, like I said earlier, in the primary school, secondary and tertiary, and also in the workplace, in the employment system, they should train maybe for instance, new employees now, when they are coming in, they should pass through what is called mental health training, awareness. To the extent that when you see someone with mental health condition, you don't just shame the person, you don't stigmatize, you don't discriminate the person. And also there should be a consistent awareness, and discrimination against shaming or maybe people with mental health, so that they find it easy, to open up. Because one thing is open up and another thing is not getting the desired response which you wanted. Again, like I also mentioned, to make sure that person with lived experience have privilege for employment in the civil service sector, to give them opportunities for employment. Not that they won't perform their taxes, but they should have a supportive system to see that when they are doing their tax, they should give them privilege of maybe taking a day off or taking a break, coming in once, maybe twice in a week or 3 times a day, or like something like that, that you make them to be accepted. Let me use that word. They should be accepted into the community, because it is not of their own making. They didn't choose to have mental health condition. They are not born that way. They are not meant to be that way. but it's just that circumstances surrounding them made them to feel that way. And this can happen to anyone. Like I said, this can happen to anyone. So far, you have a brain, and you don't even know who the next person might be. So what should be done is available support system at every designated point. In primary schools, because we have seen cases of primary school students now committing suicide, secondary school students, not talk about tertiary institution. Most of them, where they can't deal with the stressors, stressors of life, they tend to take their life. And not that they really want to take their life, but they were helpless. They were hopeless. There was no way to search for help. They should also equip what we call primary health care centers, to be able to attend to such persons with a mental health condition. But persons with mental health condition, at times they're always cited at the rural area. They don't have maybe funds or maybe resources to get to the urban area where they will be accessed help. But we should have a support system that will give person with mental health condition basic care. They should have access to basic care in terms of medications too. And like I said earlier, so allocated funds to them. Not everybody with mental condition can afford their medications. And this is not that they are also rooted in medication. There's what we call CBT, that is cognitive behavioral therapy. For instance, now, if you speak with a friend now, maybe your own friend, or maybe speaking with them, not necessarily like they need medication, but the words you speak to them. So I said, the teachers, employers, CEOs, government officials, they should be trained, that, okay, we have this mental health training today. You should call psychiatrists to train them, These are practical ways you can start from there. And like I also said, so we should also inculcate, like we have education sector, agriculture, we should also have peer support workers, inculcated into the civil service scheme. We have what we call, maybe, okay, I'm a laboratory scientist now. We also have radiographers, we also have physiotherapists, we also have nurses. There should be a space allocated for peer support workers, in the civil service group. So this peer support workers, what do? They are person with lived experience. They are not ashamed to talk about it. But what they do is that they encourage people with mental health condition. They help them with hospital accompaniment. They remind them to use their medications. To talk about, like, there's what we call tree of life. They talk about what they've achieved so far. They help them to set goals where they are going to, what they really want to become. Such practical ways. What I believe we can get that together. We can make it. Together, all of us, we can give these people, a hope and make their dreams come to life. Thank you.
Thank you very much for this very, very practical. I like your suggestion around peer support. There's this favorite example that I like to use. So I like to say every time. I remember during the HIV and AIDS, when it first started, the mass awareness didn't work until the strategy moved to peer support, peer engagement. And then people felt comfortable, to start speaking, because you can see, yes, it's also your fellow human beings like you that are going through the same situation. So it's not a death sentence per se. And then, of course, your statement around budget, I know it might sound, what do we mean? Why should we start giving people money? No, you're very right. And that is what is, in a fancy language, people say reasonable accommodation. And if we truly want to promote inclusion and equity, then what you said is absolutely also very important. And hence why we talked about the resources, the budget. Because, for example, let's say we're doing elections now, and there's somebody that, that perhaps cannot see, is blind, and then we do not have a braille election material. So how do you expect that person to participate? Or maybe perhaps he doesn't even have the education anyways. So those are the kind of things that we're saying, and totally very right. So thank you very much to all our speakers once again. I would like to ask us to please give them a very, very sound round of applause for taking their time to share this experience with us. Thank you very much. So we have just 15 minutes to round up. Thank you very much. I can see the applause all coming. So we have just 15 minutes to round up. But of course, I will not round up without giving you room. So maybe perhaps you can spend 7 minutes to hear your reactions, your feedback, your questions. We already have one question in the chat box, which I will perhaps start with that. And it's from Razak. Awal, I've seen you. Certainly you'll be the first once I read this question. So maybe if we can take notes of the three of the questions, and then we can. You've put down your hand, so you don't want to ask again. Okay, so I presume you're not asking, but please, if you have any question, feel free to raise your hand or use the chat function. So one question by Razak is that, what is the role of domestic violence on suicide, and how can families, extended included, and the community mediate in private family matters to save victims? Wow, that's another reality, right? There's lots of people dying in silence. Any of our speakers wants to take that, or should we pass that on to the Secretariat? All right, Prof.
Okay, thank you very much. I think that's a very important question. Incidentally, I run an organization called CHILD, where, as a matter of fact, we started working on attempted suicide because of our work in domestic violence. Domestic violence and other types of sexual and gender-based violence, rape, sexual assault, etc., tend to be one of the triggers for mental health conditions, but also suicide attempts. I saw that question and I thought that's a very important question. It's a situation that can cause extreme trauma and in some cases ongoing trauma, including for children who grew up in that sort of environment. There's various, without getting into too much detail because of our time and because we have a particular focus for this particular webinar. In different states now, we have various outlets for reporting cases of domestic violence. Unfortunately, we're not using them as much as we can. In Lagos, where I'm currently based, we have the DVSA, which is a government-established agency that works on this, and they actually do quite a bit of work. And I think one of the things that we can do here is to highlight, to emphasize those outlets. More and more, some of our organizations, ours included, have worked on training the police to bring domestic violence outside of what was typically called, family affairs and so on, and begin to recognize that there are, laws against that. We've also worked in the past with psychiatrists and other mental health providers to support people who are going through that sort of situation, and there is help. So the point I really want to make with this is that there is help out there. We may not get into all the details of it here, but to emphasize that there is help, and that I think it was Yinka that talked about not looking away and stepping in, even if that means just providing information as to where to get help. I know, for example, that in Lagos that they're very, very active, and they also work with mental health providers, because we find, like I've said, that is something that continues to be problematic. So you can look on our website. We have, some resources, that set out where you can get help if there is a question of DV, and of course you can reach out to us. Details are also on that website. Here I'm referring to chel.org, not to the National Task Force, which is clearly focused on the criminalization of attempted suicide. Thank you.
Thank you very much, Prof. So maybe just before we proceed, can I ask us to please just take out our phones, take 30 seconds to follow the task force on Twitter, join the conversation, because we really, really want to have all of you part of this this journey, because the success is all ours, as we indicated here. So please follow the task force on X. You can see it on the chat function, the CRIM, DECRM, suicide TH tax or TF task force. You see the link. If you go through the chat function, you'll see. And also you see the handles for CHELS and that Prof just talked about, that you can see additional details on domestic violence and mental health. So please take just a few seconds as we round up this conversation so that you can have it. So I'll be taking the last question from, although Mohammed Nasser also made a suggestion, which is integrating this with telecommunication services, service providers to provide helplines or call as well. Yes, I know a lot of organizations have toll-free lines. I know She Writes Women, for example, where one of the speakers is from, Adiola, have a toll-free line that you can call for some support services, and a lot of other organizations. But yes, you're totally right. So yes, I think there's another question. All right, so I think maybe we'll round up the question, but please do share your comments.
There's another question, James in Goodsway. So he wants to know if in his states the suicide prevention protocol put out by the FG is yet to be domesticated and the suicide prevention committee is yet to take off. What can or how can partners help in this regard? I am talking from the policy angle. I work at the State Ministry of Health as the mental health desk officer. I think this is a perfect segue into Dr. Joe's.
Excellent, exactly. So I think that's a prompt for us to move into our next item on the agenda as we try to wrap up, which is inviting the National Mental Health Coordinator to give his remarks. And also, hopefully in that remarks, he will respond to the question you just asked. Dr. Joe, over to you, please. I'm sure he's struggling to unmute his mic.
The struggle is over. I've found my hand on the unmute button. So thank you so much. It's been a very great time out today, and we want to say a very big thank you to all the speakers who have really brought life to this conversation, and we are very grateful, and it's been a great progress. Well, maybe I don't have much to say, but I know that the task force has been up to its task, and we will thank everyone that has been part of this great movement. There are a lot of things that are coming up, and Mr. James, like you brought up the issue of the task force and what is happening at what's it called, at subnational level, and maybe for Benue State. I think maybe you can speak more to that. But the truth is, like we have said, that this thing, it takes all of us. But one good thing that I'm very happy that we as a country, that the narrative has changed about mental health in the last 4 or 5 years thereabouts. It's no longer more just about policy starting and ending at the national level. We now have state mental health units who are supposed to take lead for the governance and the advocacy for stepping down whatever is happening at the national level. It will take us time before we get there, but I know that we are not where we used to be. And well, I'm not giving an closing remark. That is for the chair. But let me just say that this conversation continues, and I know that in order to just keep the momentum going, we've listened to lived experience, and the next one, the next in our webinar series in the month of July, we're going to come out with the day specifically, but we will be talking about youth involvement in decriminalization attempted suicide. What's the rationale? What are the strategies and call to action? Because if you are saying there's nothing for us without us, we know that suicide is the second leading cause of death among young people. And so it's no average youth wants to end their life. So we need to listen to them, and their voice, we are bringing it on the table. Nigeria is committed to decriminalization of attempted suicide, not just by the work of the task force, but a lot of things that has gone on through the task force. So the task force is not just to tick boxes. Great work has been going on. This is having this webinar series is just like the front end of it, but we are telling Nigerians that a great progress have been made in the journey towards the decriminalization of attempted suicide. And I want to end on this note that let us make this September a September to remember. And what do we mean by that? That come the World Suicide Prevention Day for this year, 2026, in September, that Nigeria will have decriminalized attempted suicide. All of us can do it together. Thank you so much. Over. Mr. Abdulaziz, I've handed over to you.
Okay, you can hear me?
Yes.
All right, excellent. I think I'm beginning to have issues with my network. We have just 3 minutes left. I think my work here today that I've been assigned by the task force, by the chair, honorable chair, is done. So I would like to thank especially our 3 speakers today for sharing their stories, and I'm sure it has done a whole lot. I personally learned a lot, and I believe to really contribute to our work going. And I'll be signing out, but I'll be handing over back to the chair to give the closing remark and send us all home. Over to you.
Okay, thank you. Before I give my closing remarks, please, can you take a quick picture together? We've lost a few people, but it's still fine. We still have a good number. Can we just take a quick picture? If you can, please open up your camera. Okay.
And don't forget to smile.
Right. Please smile. Are we ready? Combs, please take the picture. And can we mute those that are talking who think the meeting has ended? Okay, quick one.
So they wouldn't.
Okay. Thank you very much. Thank you so much. So I don't think I have a lot to say. Thank you so much to Yinka, to Adeola, to Olayinka. I hope that others are as blessed as and inspired by your words as I have been. If there's nothing else that this shows us, it can be anybody, it can be any of us who has the kinds of needs that we've had at different points in our lives and that we have shared in our experiences, which makes this topic all the more important. So please, thank you so much for your not just your courage in sharing that, but in the life that you live. You guys are all extremely brilliant people doing amazing things. And if you take nothing away from this, it's to realize that this humanity, all of us are human and we can go through stuff and we have to be there for each other. Thank you so very much for sharing all of that with us. And thank you to all of us who are here, who are interested in this course and interested in moving this conversation forward. On the chat, we have shared the Suicide Prevention Strategic Framework developed by the Federal Ministry of Health, which Dr. Joe has spoken so eloquently about. Please download it. We want the message to go far and wide. All of the questions, most of the questions, I didn't want to get into it, but most of the questions we asked, many of the answers can be found in that very detailed document, looking at everything from telecoms to education to risk assessment at various levels, etc. So please feel free to download that on there. Please follow us on our platforms. We've already been told that. Please follow us and help us to amplify this message, help us to get this message out there that suicide is preventable, that we are looking at this from a public health and a human rights perspective, and that we're using the law. We're going to be seeing the law being used for good things. The National Mental Health Act actually makes the provision for a national suicide prevention strategy, which is why the Federal Ministry of Health has done that. So when we talk about the National Mental Health Act being implemented, we can see that while it's not completely implemented at this time, that there have been efforts, and we hope that we can help to amplify these efforts. We hope that you come alongside us on this journey as the National Task Force on Decriminalization of Attempted Suicide to continue to, amplify the message about decriminalization. Decriminalization, we look at decriminalization as the very first step to suicide prevention. If people will feel afraid to come forward because they are going to be criminalized, then we haven't done very well. And that's why the government is taking this step, and we hope that other people can amplify these messages. Thank you very much. Perhaps another day we can talk about employers, but for our next webinar, which we're inviting you to in the next month. Again, if you follow us, you will get all the information. Is going to be on the youth, a very critical part of our society. In fact, Nigeria is a young society because most of us are young, so extremely important. So please, please, please join us for that. And let me go back to Abdul. Thank you so much for a brilliant, brilliant webinar. Thank you, Abdul.
Thank you very much, Prof. On this note, I would like to say have a lovely evening, everyone, and see you on our next webinar. And don't forget to follow on the links that we've mentioned. Have a great evening, everyone.
Yeah, bye.
Bye.
Bye. Thank you. Thank you so much.
Bye-bye. Thank you.
Bye, everyone. Excellent moderating.
Hi, everyone.
Thank you, Abdul. Thank you so much,
thanks
Abdul.
to the speakers.
Fantastic, fantastic. Thank you, Yinka. Thank you, Adeola. Thank you, Olayinka. Thank you, everyone.
Thank you,
Thank you for
everyone.
everybody that joined. Thank you, Onyinyechi. I just saw you now. Thank you, everyone that joined. Thank you, Oge. Thank you, Dr. Ogunwale, for joining, despite the fact that you were in transit.
I was waiting to explain myself. I didn't realize I had to be somewhere at that time. Oh no.
Yeah,
Anyway,
but you still joined. That made a huge
I had
difference.
to.
Thank you so
I had
much.
to.
Thank you,
Thank
guys.
you.
Thank
Thank
you so
you.
Abdulaziz,
Thank
much.
you.
that was
Thank
fantastic.
you.
Thank you.
Thank you. It was beautiful. Thank you. Thank you to our speakers. Just brilliant. Thank you.
Brilliant,
Okay,
brilliant.
guys. Have a great evening and God bless you.
Yeah, bye bye.